Donc, bonjour à tous. J'ai le plaisir d'animer cette session dont le titre est « La pandémie silencieuse, un appel à l'action ». Donc, je suis Dr Vincent Oliva, président de la Fédération des médecins spécialistes du Québec. Je souligne la présence de nombreux membres de notre conseil d'administration, donc plusieurs médecins spécialistes qui sont ici et plusieurs membres de notre équipe de la permanence aussi, qui témoignent de l'importance qu'on porte à ce sujet-là. Et on parle de résistance aux antibiotiques et dans le fond, il faut se rappeler qu'il n'y a pas si longtemps, on a fait affaire avec la tuberculose qui était résistante et on se rappelle qu'on était dépourvu et c'est à ce genre de menaces qu'on fait face encore aujourd'hui avec ce nouveau phénomène de résistance aux antibiotiques. Ça a été placé dans les 10 plus grands problèmes de santé par l'Organisation mondiale de la santé. Donc, ça vous donne une idée de l'importance. Donc, on va parler aujourd'hui du contexte de cette résistance-là, par quoi elle est causée, quelles sont les conséquences. On va parler aussi du rôle du diagnostic dans les maladies infectieuses. On va aborder aussi les partenariats qui peuvent être possibles pour combattre cet ennemi. Et on va également aborder la question de l'intelligence artificielle et le rôle de l'informatique quantique, donc un sujet quand même assez intéressant. Et d'abord, je remercie nos 3 panélistes qui sont avec nous aujourd'hui. Donc, d'abord, à ma gauche, Dr Mark Miller, qui est infectiologue et qui est aussi directeur médical et vice-président exécutif de bioMérieux, Donc, on a aussi Dr Lawrence Rosenberg, qui est chirurgien, mais qui est aussi président, directeur général au Réseau universitaire intégré de santé et de services sociaux à l'Hôpital général juif. Et finalement, Dr Karl Weiss, qui est chef de la division des maladies infectieuses à l'Hôpital général juif. Il est aussi président de l'Association des médecins microbiologistes infectiologues du Québec, et professeur de médecine à l'Université de McGill. Donc, bienvenue à vous 3. Merci d'être là. Je commencerai peut-être par une question au Dr Weiss. Dr Weiss, c'est causé par quoi cette résistance aux antibiotiques? Pourquoi est-ce qu'on fait face à ce phénomène?
Alors, bonjour, et puis je vais m'exprimer plus en anglais. So, antibiotics, it's something which is relatively new. The first antibiotics started in the 40s. And antibiotics are targeting living organisms. So when you try to attack a bacteria, eventually the bacteria will find a way to defend itself and become resistant to the aggressor, to the antibiotic. The antibiotic are also being used on the world scale, I would say, for everybody around the world. And I always tell people that the difference between infectious diseases and any other condition in medicine is if I tell you that your neighbor has diabetes, I mean, you will be very sorry for your neighbor. But if I tell you that your neighbor has Ebola, the first question you're going to ask yourself is, when was the last time I saw him or her? Because obviously you'll be concerned. So antibiotic resistance is caused by many different things. We use a lot of antibiotics in agriculture. About 80% of the antibiotics are being used in agriculture. We use only 20% in the human population. The second thing is there are different laws around the world. In certain countries, you can prescribe antibiotic with a prescription, but in other countries, you can buy antibiotics over the counter, you can buy antibiotics in a grocery store, you can buy antibiotics anywhere, and obviously that drives resistance. The third thing with antibiotic resistance, it's a growing issue. There's a lot of counterfeiting in terms of antibiotic production around the world, where you have low-quality antibiotics. And what happens is when you give these antibiotics to people, you don't really kill the bacteria you intend to kill, but you promote up to a certain point resistance. And I think COVID was the best example of something that can spread very quickly. When you travel around the world, you come back with resistant bacteria in your system, not being sick necessarily, you're not necessarily sick, but you become a carrier of these bacteria and you introduce them in your environment, and eventually they'll spread and create issues within your own institution, your own province, your own country. So antibiotic is definitely a huge challenge. There was also the concept in the late 70s, well, I would say mid-70s, that infection were something of the past, and that we had enough antibiotic and we shouldn't be worried about anything else. So, but let me tell you something important. We would not be able to practice medicine, we do it today, without antibiotics. If you have no antibiotics, you won't be able to give chemotherapy treatment, you won't be able to do complex surgeries, you won't be able to do transplants, there will be a huge part of medicine that will be totally impossible. So antibiotics are extremely important, but the problem we have with antibiotics is very often, from an investment perspective for a company, you prescribe an antibiotic for 5 days, 10 days, and that's it. Whereas if you have high blood pressure or diabetes and I give you a medication, you can take the medication for 10 years, 15 years. So the investment is not very rewarding for many of the companies. I mean, the trademarks and, are not really protected for a very long time. So investment in antibiotics was less and less. And what happened is we went from 10 to 15 new antibiotics per decades a few decades ago to 2 or 3 in the last decade. So there is emerging bacteria in terms of resistance. There are less potential antibiotics that we can use. We have an older population with more challenges. Many years ago, we were more careful giving chemotherapy to people who are older. Today, we treat people who are older with more intense chemotherapy. We have all these new treatment in medicine that will lower your immune system and make you prone to have more infections. And you have people traveling around the world. So we really are at a crossroad in terms of antibiotic resistance. And when we were mentioning the pandemic, I always say, the COVID-19 was a tsunami, huge wave. Antibiotic resistance is like bad weather, bad waves coming one after the other, but for a very long time.
Très intéressant. On reviendra peut-être aux impacts. Dr. Miller, est-ce qu'on fait assez de diagnostics?
La réponse courte, it's no, we're not doing enough diagnostics. But really, to follow up on Dr. Weiss's comment, I know that everybody calls antibiotic resistance the silent pandemic. I prefer to call it the pandemic without an end. As bad as COVID was, it lasted 2 to 3 years. Unfortunately, lots of people died, lots of people got sick, but there was an end and it's gone into the background. With antibiotic resistance, it's not the same. It will continue, it will get worse. It looks like it's getting worse. We know that there's about 1.3 million people dying around the world every single year of antibiotic resistance, and there's not enough diagnostics being used. So we believe, obviously, at bioMérieux, we make diagnostics, mostly for infectious diseases, and we believe that diagnostics are absolutely crucial, pivotal to fight against antibiotic resistance worldwide, globally. And why is that the case? Because essentially, without diagnostics, we are totally blind. We don't know what's going on. With antibiotics and with diagnostics and the use of diagnostics, you know where antibiotic resistance is, you know how bad it is, you know if it's spreading, you know if it's getting worse or better. You know which types of antibiotics will no longer be good, which will still be effective for the patients. So diagnostics really give us all the information that we need in order to do surveillance for antibiotic resistance. And diagnostics are not used enough in the world in order to give us that portrait, that surveillance data, that knowledge. In many countries, there is no national surveillance, and we only get little snippets, little pictures of what's going on. On top of surveillance, obviously, diagnostics are very, very important for an individual patient in order to know whether they need antibiotics or not. Many viral infections do not need antibiotics. Most do not need. And giving antibiotics will not do any benefit to the patient, but will lead to resistance development. On top of that, infection control is very heavily dependent on diagnostics, diagnostic testing that tells you who has what. Do I need to isolate this patient? Can they transmit it to somebody else, their neighbor, their friend, their family, etc.? And then we also use diagnostics globally to help the biopharmaceutical companies to develop their new antibiotics. You've heard from Dr. Weiss that there aren't many new antibiotics being developed because of the lack of economic and innovation incentives. and the market out there that is not very conducive for new antibiotics, but it's the same for new diagnostics as well, which I'll get to. But we help the biopharmaceutical companies by delivering really good targeted diagnostics in their clinical trials, because their clinical trials need to be conducted with their antibiotic targeted at very specific patients. And without diagnostics, they do not know which patients would benefit from their antibiotics. So we can give them these diagnostics that target the right patients for their clinical trials, making their trials much more efficient, much faster, less money, and more likely to succeed and get to the marketplace. We have problems in diagnostics. Getting back to your first question, is there enough diagnostics being used? And the answer is no, because we have tremendous market access issues in diagnostics. The number one problem is that there is no standardized, harmonized way of showing value of a diagnostic. So there's no what we call health technology assessments, or HTAs, that are harmonized and standardized between countries to show the value of a diagnostic. And without that value, it's not reimbursed appropriately. And without the reimbursement, there's no incentive for innovation and, the development in research and development. I think the innovation part is important because we need to develop novel diagnostics the same way that the biopharmaceutical companies need to develop novel antibiotics. Everybody talks about the need for antibiotics and vaccines, but we also need innovative, rapid, actionable diagnostics. And without the incentives and the market access incentives, we are not going to develop those diagnostics. I always say we can develop the best diagnostic test tomorrow, but if there's no market access, if there's no reimbursement, if there's no value determination, then nobody will use it. And in that sense, we really are heavily dependent on partnerships. And I know you're going to talk about partnerships, but partnerships to us in 2023 and moving forward are extremely important. None of us, no biopharmaceutical company, no diagnostic company, no vaccine company can do this all alone, especially you've seen during COVID, but there's many, many examples. We need private-private partnerships. We need private-public partnerships. We just need consortia. We need partnerships that really, where we work together for the common goal. And there's lots of examples out there of government, non-governmental, private, public getting together, and we're much more successful. So, short answer is not a lot of diagnostics being used. We need to address it better, but they are pivotal for fighting antibiotic resistance.
OK, on pourra revenir au partenariat. Dr. Rosenberg, l'intelligence artificielle, on parle d'intelligence artificielle partout. Comment est-ce que l'intelligence artificielle peut nous aider dans cette lutte contre la résistance aux antibiotiques?
I think artificial intelligence actually is a good link or catalyst between the issues of diagnostics and developing new antibiotics. One of the key areas for the application of AI will be drug discovery and new drug development. That's clear. AI can accelerate the process of discovering and designing new antimicrobial agents. By analyzing vast amounts of data, including genomic information, chemical structures, and medical literature, AI algorithms can identify potential new drug candidates with high efficacy and reduced resistance. Quantum computing, I would add, as it comes on board over the next few years, very short few years, can also contribute by simulating and optimizing complex molecular interactions that previously could not been studied, simulated, or well understood, enabling more accurate predictions of drug behavior and efficacy as well.
Je vais revenir à Dr. Weiss, puis on pourra peut-être revenir un petit peu plus tard. Dr. Weiss, les conséquences de ces résistances aux antibiotiques, premièrement, économiquement, est-ce qu'on peut chiffrer les impacts? Puis ensuite, sur la mortalité, si on compare les effets qu'on a eus avec la pandémie, on sait à peu près combien il y a eu de décès, puis il y a de la morbidité tardive avec la COVID longue. Est-ce qu'on peut comparer ça en termes d'ordre de grandeur, à la fois en termes économiques et en termes de morbidité, mortalité?
Yes, for sure. So there are several studies. One of the biggest study was done by the World Bank in 2016, and in fact, it's a document which is available on the web, and you can certainly access the document. And basically what they said that taking 2019, obviously pre-pandemic, as a baseline, the world GDP would go down in 2050 between 1.1 and 3.8%, depending on the scenario. So the most optimistic scenario would mean a world GDP going down by 1.1% in 2050. The worst case scenario would be 3.8%. But in terms of cumulative loss, we're talking about $100 trillion by 2050 because of antibiotic resistance. And there was two other studies. One was done by KPMG, and another one was done by the British government. In fact, the former UK Prime Minister, Neil Cameron, asked a group of economists in 2014, and it's called the O'Neill Report, to look at the potential implication for the UK, but also for the world, as a strategic evaluation of what will happen if really we start having more antibiotic resistance. And they ended up with more or less the same conclusion, that we're talking about trillions of dollars in terms of loss within the next 10 or 20 years. So the economic loss is going to be huge because people are dying. It costs more to treat these people. People are not working. They're like, you don't have your workforce. People are not traveling. Look what happened with COVID. If you start having an outbreak of a very resistant microorganism, the answer will be from many governments to close the borders again, to stop traveling, to stop tourism, all the consequences. When you go somewhere around the planet, one of the first things you ask yourself is, can I drink the water? And if obviously there are resistant bacteria in the water and you have an outbreak somewhere, that can have a huge impact on tourism and business. Now, that's the dollar thing, I would say. But there is, unfortunately, a huge, impact in terms of mortality. So the scenarios are obviously, different, but we can talk about several million people dying every year, in the world because of antibiotic resistance. So if you add, and this is why we call it the silent pandemic, it's not like a big, upsurge of death like when we saw with COVID. It's something that will be more on a continuous scale and that won't necessarily be registered immediately. But if you accumulate and add all this mortality and the morbidity and the cost to the healthcare system, and we have everybody, especially in the Western world, where we have an aging population and things are costing even more to treat people in hospitals. So if you keep people in hospital for a longer period of time, if you don't have the beds, because these people are occupying these beds, then you have a huge burden on the system. So antibiotic resistance is not just like a kind of potential threat or something which is like virtual or something that might happen. We do live with antibiotic resistance, and it's just going to be a growing problem. And because people are traveling around the world on a continuous basis, whatever happens, in the other part of the world can end up, in your environment very quickly. So we always tell people, you're always 24 hours from any potential resistant bacteria around the world. So the economic and I think the human consequences of antibiotic resistance will be huge. And I was mentioning before that we won't be able to transplant medicine, hemodialysis, oncology. We won't be able to treat people with cancer if we have no antibiotic. It's very simple. Because people with cancer, when they're on chemotherapy, the biggest threat for them is infection. So if you're not able to treat these people and take care of these people, the mortality associated with this will be gigantic.
Est-ce que la mortalité augmente tranquillement ou est-ce que c'est quelque chose qui s'accélère? Et puis est-ce qu'on risque à un moment donné de faire face à une crise où il y a une bactérie résistante puis on vit une autre pandémie mondiale? Est-ce que c'est des choses qui peuvent arriver?
It's always a possibility, but the population in the Western world mostly is getting older. So they're at high risk of having surgeries, complications, all kinds of procedure. So they are at high risk of having this resistant bacteria and therefore dying because of it. Now, in the rest of the certain part of the world, for example, the African countries where the population is much younger, but where resistance is more of a problem because there is no control on antibiotic usage. So there, the problem could be we have resistance to malaria, we have resistance to tuberculosis, we have resistance to other conditions that can obviously trigger some major problem. And with a huge impact on the economy, because if you have a young, healthy population of your country being affected by infectious conditions, they're not able to work.
And actually, in most countries, we actually don't know, because there are very few countries that actually do surveillance for how much antibiotic resistance they have, how many people are infected, and how many people die. And they don't code it properly, they don't do national surveillance. So when it comes down to that very important question is, how big is it, how bad is it getting worse? We actually, in most countries in the world, don't know. And that's why publications like the one in Lancet that came out a few months ago that really did a comprehensive look at how many people are dying of antibiotic resistance and coming up with numbers about 1.3 million every single year. It's very awakening, because we didn't know those numbers before. And certainly in individual countries, we don't follow it that well. But it's a great question that we need to answer.
Tout à l'heure, vous parliez de diagnostic, puis juste pour que les auditeurs comprennent bien, évidemment, il y a le diagnostic d'un patient qui arrive avec de la fièvre. On veut s'assurer que c'est vraiment une bactérie et pas un virus pour s'assurer qu'on peut donner des antibiotiques. Mais est-ce que l'aspect diagnostique touche aussi la question, est-ce que cette bactérie est sensible à cet antibiotique?
Yeah, I mean, so that's how we use diagnostics is really a crucial question. And exactly like you said, the first use is when somebody comes in to their healthcare provider, a clinic, a hospital, an emergency room, and they have a fever or they look like they have an infection. And the number one question is this a viral or a non-bacterial infection, or is this a bacterial infection that I would need antibiotics, that they would need antibiotics? And diagnostics can help differentiate those two. We have a need for better antibiotics in that area, but the number one question that most healthcare providers ask is, with this person in front of me, do I need antibiotics? Do I need to give them or not? That's the first one. The second one is, once you say, yes, it is a bacteria, which one is it? Because that can predict what they're going to respond to, and specifically which virus or which bacteria. Do I need antivirals? Do I need antibacterials, etc.? And then the third one, which diagnostics really are absolutely crucial, is once I know it's that bacteria, which antibiotic can I not use and which antibiotic can I use, because this one's not effective and this one is effective, and so I have the best chance of giving this patient the best chance for an outcome and survival, especially in severe infections, by using this particular antibiotic without going too broad and causing resistance, and without using the wrong one. So there's many different ways that diagnostics can be used with the patient in front of you. Yeah.
Do you have pressure from patients to get antibiotics?
So the biggest, I'm sure everybody in this audience will appreciate that our biggest problem in using diagnostics or misusing antibiotics is both patient behavior and healthcare provider behavior. The behavior of patients or parents of children demanding antibiotics and wanting antibiotics, thinking that their child or they will get better with antibiotics, even though it's not needed. And for the clinician, the healthcare provider, to just give a prescription for antibiotics, they leave the office, it's 2 minutes, and they don't have to spend time explaining why you don't need antibiotics. So that behavior component is a very, very crucial part of antibiotic resistance and why we still see antibiotic resistance.
And one very important thing about testing today, I think COVID taught the world, the people, how to test themselves. Mm-hmm. So this was something that people were not doing before. And the biggest revolution in medicine in the future will be point-of-care testing. And point-of-care testing is when the patients themselves will decide, or clinics, or there will be a lot of, I would say, decentralization of testing. And the technology is moving very fast, whether it's artificial intelligence, but other testing too, where people will be able to do their own testing. And I think this will have to be taken into account into the future. 10, 20 years from now, you will see an explosion, especially in the field of infectious diseases, where point-of-care testing will become very, very important. And all the questions that Dr. Miller raised in terms of access, cost, reimbursement, etc., will be crucial in all of this. Remember, when you had COVID and you went for an airport and they wanted to test you, imagine, but they can do this with everything technically. So in the future, that would be a possibility for all kinds of reasons and all kinds of things. And it's coming very fast.
And getting back to Dr. Rosenberg's point is that when we have point of care testing, like many other companies, again, it's the question of reimbursement and access and who's going to pay for it, but the technology is there. But every time we roll out a point of care test, they ask us, is it connected? Where's the connectivity? Where can I get my data? Can I use this for surveillance purposes? Can I use this for population and public health management? And so the connectivity part and the AI part is really important, aside from the technology, which we all have.
It's actually a very interesting point because we have the only hospital-at-home program in Canada at the moment that's able to monitor patients 24/7 around the clock, with nurses staffing a command center virtually always. We're introducing point-of-care testing into that hospital-at-home program. And where AI becomes important is not so much in early detection or drug discovery, but it's actually in how the devices work. The point that the at-home point-of-care devices are all loaded with AI algorithms that, in part, instruct the patient at home how to use the device and how to interpret what they're seeing. These are really very sophisticated devices that are now available. And I can tell you that the biggest obstacle or resistance to their introduction are our physicians. Mm-hmm. And it's not because the data isn't connected back to the hospital, because we've set up a cloud-based connection back to our command center for all these devices. It's the physicians who think it's going to create either more work for them, or at some point they're going to have to leave the hospital to make a home visit. So there's really a cultural change that's going to be required as this technology gets introduced.
C'est de la résistance au changement.
Exactement.
OK. Vous parliez aussi d'informatique quantique. Concrètement, là, ça s'intègre comment?
There's at least 3 or 4 areas where I think artificial intelligence, together with the evolving quantum computing, is going to make a huge difference. One is in surveillance and early detection, for sure. AI algorithms can analyze huge data sources, diverse data sources, including electronic healthcare records, laboratory results, environmental data, to detect patterns and trends that are indicative of antimicrobial resistance emergence before anybody else really recognizes what's going on. And so early detection of resistant strains can help public health agencies and clinicians to take proactive measures to prevent the spread of AMR. In addition, there's the whole issue of AI and predictive analytics, where AI can be employed to forecast AMR trends and identify high-risk areas, both globally and locally within specific healthcare facilities. And this is going to become an evolving area of use of AI in the next short while. And then finally, optimization of antibiotic usage. AI algorithms can analyze patient data and clinical guidelines to optimize the usage of those antibiotics. And by considering factors such as infection type, severity, and patient characteristics, AI will be able to assist healthcare professionals in prescribing the most appropriate antibiotics at the right dosage and for the right duration.
Merci. Dr. Miller, on a abordé tout à l'heure les partenariats. Est-ce qu'il y a des modèles qui existent pour les antibiotiques, pour la résistance aux antibiotiques?
Yes, luckily there are some successful models of partnerships. But before we get into those, certainly from the private sector, today, 2023, the world is very complex. The world is very complex in terms of geography, in terms of politics, in terms of the regulatory environment, which was discussed during the previous roundtable, the innovation environment, financing. It's a very complex world. And certainly we in diagnostics, we believe that we cannot do this all alone. I think the previous thinking was that, every company can deal with this on our own. We have our own R&D departments. We have our own innovation and financing, et cetera, et cetera. But it becomes very clear that we're much more powerful together. And there are some good examples. So certainly in the United States, There's BARDA, which is a government agency, a federal government agency, which has been very successful in combining private and public entities together to fight against antibiotic resistance. There's the very famous CARB-X group, and CARB-X is very unique because it's the Boston University, it's 3 governments, the US, the UK, and Germany, and 2 nonprofit organizations, Wellcome Trust and the Gates Foundation, and they have all gotten together to fund projects to fight AMR, antibiotic resistance. Very successful projects. And I think that's a good model. On the European side, we see groups like EIT Health and IMI, they're trying to copy the BARDA CARB-X model in Europe by doing something called HERA, which is for health and responsiveness. And I think because the model works so well in the United States with also international funding, so we have some of these. Certainly, private, we have partnerships with certain biopharmaceutical companies. We had a very successful program with Entasis, which is very public. They created a new antibiotic, which was very targeted, and we gave them the diagnostics in their clinical trials to target those patients, a very successful program, which led to approval by the FDA, clearance of their antibiotic. So there's private partnerships, there's private-public, there's public-public, there's consortia, like in Europe, and I think there's some good examples out there, but we need to do more.
Être un gouvernement, on voit ce phénomène grandir, on sait que ça va continuer à augmenter avec des conséquences économiques. Est-ce que les gouvernements en font assez?
Who wants to answer that? And I think there's examples of governments that have been very proactive. So Dr. Weiss mentioned the United Kingdom. The United Kingdom views antibiotic resistance as an international threat. As I said, the pandemic without an end. And they view it as giving money both within the UK and outside the UK to fight. And they're doing a lot of work in Africa, for instance, with the Fleming Fund, to fund labs to do diagnostics for antibiotic resistance and to fund the infrastructure for sustainability. So I think the UK is one of those governments that really sees the international impact of AMR, the negative impact, and they need to do something. Same thing with the German government, same thing with the United States government. There are other governments that have not kind of risen to the occasion yet in terms of this kind of international financing. But certainly in those models, there have been some very successful programs, like what I mentioned, plus the Fleming Fund, which is really an emblematic program to help Asia and Africa to fight antibiotic resistance.
Dr. Weiss, vous êtes clinicien. J'imagine, premièrement, que vous avez une perspective sur ça.
Yes, for sure. I mean, and I agree with Mark that the majority of governments, at least some of the G7 governments like the US and the UK, probably made huge effort in the past. Canada is trying, but I don't think we're at the level of the others. I think in terms of surveillance, we can do better. Overall, I think that's the number one thing. The good thing now is there's a momentum for awareness. I think the general population knows about infectious diseases. Even if you were living in a cave in the last 3 years, you were aware something happened in the world in terms of infection. So if you talk about infection, antibiotic resistance, people will be very receptive. There is also a trend in the population to know that antibiotic might not be that good, so they're less, I would say, they're more, I would say, reluctant to get antibiotic compared to, let's say, 2 generations ago. So there are positive things coming from the public. The public is more educated from that perspective, but we really have to go to another level in terms of surveillance, integrating our database, and having also what I would say, and what I would call a kind of a strike force that can be mobilized very quickly if there is an emerging problem. The problem with the government is there is a crisis. They have to face the crisis. Once everything is over, it's like an army. You don't want to keep an army, ready for another battle if it's not really obvious. So part of the problem is we had SARS in Canada 2003. We did certain things, then we decided to abandon them. When we had the pandemic, the H1N1 pandemic, quote, in 2008, we started, for example, keeping masks. But the problem is at one point the masks were kind of, thrown into the garbage because of other conditions. But I think you have to be very reactive. I have to say, because Dr. Rosenberg is with me today, and I have to congratulate him for this one, because when the pandemic started in 2020, I remember we had a talk and we said we need to buy some masks before everybody else was really talking about masks. And he took the decision to like stockpile millions of masks at the Jewish General. And this is something where, you know, people have to be prepared even when you don't see the threat immediately. And I think this is what we have to do. But there is also the necessity for a partnership with the private sector, with money coming from the private sector to finance, you know, the arrival of new drugs, of new antibiotics. Because if you're a pharmaceutical company, as I said before, if you have the choice between something for a chronic condition that will be sold over 25 years to a patient for something that the patient will have to take every single day versus something where we tell you not to overprescribe antibiotic, don't give it for a long period of time. So from a business perspective, it's a lot more interesting to go into the chronic disease condition. And that's a major challenge in terms of antibiotics. And this is where government won't be able to do a lot, except maybe give you like longer protection in terms of your trademarks and things like this. But it has to come from a partnership with the private sector.
Revenir peut-être à quelque chose d'un peu plus, disons, clinique. On a parlé tantôt de la pression des patients qui viennent avec la fièvre, qui veulent un traitement. Oui, les gens sont beaucoup plus éduqués, ça c'est sûr, mais en même temps, il y a de l'information qui est parfois discordante sur le web. On appelle ça Dr Google. Alors les gens s'instruisent, lisent un peu, puis des fois s'auto-diagnostiquent. Alors ils arrivent à l'hôpital et puis pour eux, ils ont telle pathologie, puis ils veulent se faire prescrire des antibiotiques. Est-ce que c'est quelque chose qui joue beaucoup? Autrement dit, est-ce qu'on en fait assez pour éduquer la population sur ce phénomène-là dans le contexte où l'information est plus accessible?
So we can certainly do more and we can certainly do better. I think Dr. Google is a challenge for every specialty because everybody has a diagnosis. And, you know, as clinicians, we have seen people who came to our clinic being certain that they will be dead within 24 hours. But I mean, that's part of our new reality. I think this is the way we practice medicine today. We cannot stop Google. I think, and you cannot stop disinformation coming from different areas of the world where, you know, all kinds of information will circulate on the web. And in fact, there were people who kind of on purpose sent false information and saw how this was going to be, you know, taken by everybody around the world and how the information will be transformed and broadcast, you know, to people. So this is a limitation that where we will have to fight continuously in terms of trying to give the right information at the right moment. We saw during the pandemic that, you know, you always have 10% of the population that will go against, you know, the general thoughts of what we find is science.
And this is a westernized view, but let's remember that the majority of the antibiotic-resistant infections in the world are not in the so-called West. They are in Asia, they're in Latin America, they're in Africa, where education is extremely important, but totally different. There, you need basic education about hygiene, infection control. You know, the difference between bacterial and viral is very basic. Whether they need antibiotics or not is very basic, whether they can even get them or not. Sometimes they're restricted. So there's a lot of real important education that needs to be done in developing countries, or so-called low middle income countries, which is different than what we do in the developed countries. The education, the approach, et cetera, is very different. And where we also have great obstacles in terms of diagnostics, antibiotics, you heard about counterfeit antibiotics, et cetera.
Moi, j'essaie de voir dans quel domaine est-ce qu'on peut s'améliorer pour évidemment combattre ce phénomène-là. Puis on a abordé plusieurs points. Tout à l'heure, Dr Weiss, vous avez dit qu'il y a de plus en plus d'antibiotiques, par exemple, dans les élevages, dans ce qu'on mange, etc. Ça, est-ce qu'il y a des choses qui sont faites pour sensibiliser les compagnies ou est-ce qu'elles sont encadrées dans la façon dont elles élèvent les animaux qu'on va manger après?
Okay, so this is an extremely important question because, as I mentioned, 80% roughly of all the antibiotics are being used in agriculture. And you have different laws and different rules in different countries. And I have to say, you cannot have the type of agriculture we have right now to feed the world without antibiotics. So if we stop using antibiotics tomorrow, it's going to be a catastrophe. It's not going to work. But there are countries, for example, like Denmark. Denmark is probably the example where they're really trying to use less and less antibiotics only when it's appropriate, etc. And it's very regulated. I think Canada improved significantly over the last 2 decades in terms of using antibiotics, but it's still like you can use kilograms and pounds of antibiotic if you're a farmer for certain things, poultry and certain types of cattle very easily. Whereas, to use antibiotic in humans, you still need a prescription. And there is also here a competitive edge that, some people will say we cannot stop using antibiotics tomorrow, and it's understandable. So there are huge efforts to be made in the field of agriculture for sure. Not just agriculture, also fisheries. We have these fish farms where they're using tons and tons of antibiotics sometimes in the water, which is even worse because when the water moves around, it's like in a river, it goes into the sea, and then it goes around the world. So there are a lot of challenges in the field of agriculture. And this is where we use more antibiotics. And don't forget, in humans, we use antibiotic for therapeutic reasons. We give you antibiotics because you're sick. In the agricultural world, we don't use antibiotics for therapeutic reasons. Animals are not sick. You use antibiotics to, make sure they grow faster, or you don't have an outbreak of something in your poultry, etc. So you're using antibiotics for a different purpose. And eventually we'll have to find ways of, I would say, balancing the overuse of antibiotics, including pesticides and others in the world of agriculture.
Docteur Rosenberg, Montréal est quand même assez avancé en intelligence artificielle. On sait qu'il y a beaucoup d'initiatives ici. Est-ce que c'est un bon endroit pour investir?
I think it's the area to invest in at the moment. And I'd like to come back to something that both Dr. Miller and Dr. Weiss talked about, and that's surveillance. At the moment, the only way to really optimize surveillance with respect to antimicrobial resistance is to be able to integrate access to a diverse sources of databases. Mm-hmm. Some of these are private, some of these are public. Some of these reside in hospitals, some of them in clinics, some of them in public health and government, some in companies such as McGill, others in databases and pharma companies that are producing the antibiotics. These are all siloed. And the only way to really get a handle on antimicrobial resistance and proactive automated surveillance and screening would be to somehow link all these databases in an automative sort of way. And that's where AI and quantum computing come in, because the scope of being able to do that is just not possible at the moment, given the current state of digital computing. Within a few years, with the introduction of very powerful quantum computers, this will be possible. And the only roadblock at that point will be government regulations with respect to how you access these diverse sources of information.
I think this is really crucial because we have the technology to produce a lot of this important data. And the technology is there, and I think that the informatics is getting there. We're not where we could be, but we're there. But we have, certainly as a private company, and I know many of the private companies deal with this, we have severe issues on the framework of data privacy and data ownership. So, we as a company produce the majority of the world's automated antibiotic susceptibility testing. We produce millions of pieces of information every hour in 150 countries in the world. And everybody says, if we could only get our hands on this, we would know the surveillance for resistance, we would know what's going on. But we have massive problems on data ownership and data privacy. For where's the cloud? Is the cloud allowed to be shared with other countries? Cloud computing is physically located, the servers are physically located in a country that doesn't have an entente, doesn't have a contract with another company, and there's privacy issues related to patient information, even if we strip it and anonymize it. So there's all kinds of framework issues that make it very difficult today, that is very painful. We can solve them, but they're very slow and they're progressive, whereas the technology is very tempting that we can do this, especially for surveillance, and yet the physical limitations, the economic limitations, the political and the legal, ethical limitations, mostly the ethical, legal limitations are very severe today.
Donc, vous parlez de limitation, mais qu'est-ce qui est la plus grande limitation? Est-ce que c'est l'accès aux données, ou c'est la puissance des ordinateurs, ou c'est les compagnies qui investissent pas assez?
My opinion is that it starts at the basic. Countries, for instance, Canada, the United States, if we're going to take that as an example, we don't have a code in the hospital or in the community for somebody who dies of an antibiotic-resistant infection. If they come in with pneumonia and it's resistant to all antibiotics and they die, on the death certificate it says pneumonia, not an antibiotic-resistant pneumonia. So it starts really at the basic, and this is in most countries. They do not have coding for this. Therefore, we can't count the number of patients who are dying of antibiotic resistance. Therefore, we don't know. We don't have the surveillance, and we can't act on it. So, without knowledge, there's no action. And to me, it starts basic in terms of getting the knowledge of that. I think the biggest revolution in oncology in the past has been huge databases and people registries for oncology, for cancer registries, where we know exactly who's got cancer, how many people, what kind of care they require, so that public health can be adjusted. We don't have that for antibiotic resistance.
Parfait. Il reste à peu près 6 minutes, chacun à peu près en 2 minutes. Pouvez-vous nous dire quel aspect de cette problématique-là est la plus significative et qu'est-ce qu'on peut faire pour l'améliorer? Donc, je vais commencer par Dr. Weiss.
So I think surveillance, detection, having a system in place to be able to tackle an emerging threat very quickly, like an army, where you call your reserves and you're able to mount a response very quickly. And I think we will need more antibiotics in the future. We will also have to start looking at other ways of having antibiotic therapy. We're talking about phages today. We're talking about maybe other ways of delivering antimicrobial activity. But we definitely need more antibiotics, and we have to think a little bit outside of the box in terms of the type of medication we'll bring in the future to be able to tackle this antibiotic resistance. Maybe vaccines will be better because people were not very successful, for example, to have vaccine against certain bacteria causing infection in people with lung diseases, for example. Maybe in the future we will be better with these type of things, but I think we have to have a concerted effort. I always take the example of COVID-19. COVID-19, we're in 2023. Never in history we were able in 4 years to find a virus, find a vaccine, find medication against something. So if we really want to put all our energy together, this is something which is feasible. And if we don't, tackle this threat of antibiotic resistance, whatever you saw with COVID, maybe not as big in one wave, but these continuous waves coming one after the other in terms of resistance will hit the world and will impact everybody's daily life.
Dr. Rosenberg, vous, votre perspective, où est-ce qu'on peut faire le plus de progrès pour améliorer la résistance aux antibiotiques?
I think there's two related areas, and Karl mentioned one of them earlier. Point of care, I think, is where healthcare in general is moving. Healthcare will be moving out of hospitals, moving out of clinics, into people's living rooms, and we need to be sensitive to that. The technology is there and will only improve. The limitation, as I said earlier, is doctors' resistance, which is still difficult to understand, but is a real problem, and patient education. And it isn't just educating people when they need antibiotics and when they don't need antibiotics. It's a general population education with respect to health and healthcare. It has to do with diet. It has to do with health, exercise. It isn't just when do I need an antibiotic. So I think that's a real serious populational issue.
Est-ce qu'on peut penser que, par exemple, comme ce qu'on a vécu pendant la COVID, les gens se testaient chez eux, est-ce qu'on peut penser un jour qu'on va pouvoir faire ça pour les infections bactériennes aussi?
Oui, je pense que oui, exactement, oui.
Dr. Miller, votre perspective,
peut-être plus privée ou
No, well, private, I mean, it's private, public, it's the same opinion. I don't think that the world is sensitized enough to the dangers and the importance of antibiotic resistance. I think this is an educated, erudite crowd here, and we understand what's going on. I think the majority of the world still doesn't understand how important it is. I travel a lot because of the business that we're in. I think the average person in Vietnam does not understand how important antibiotic resistance is, and yet when I go to visit pediatric hospitals, 8 out of 10 of the newborn children there who are in the intensive care unit are colonized or infected with a multiply antibiotic-resistant bacteria that they may not survive. And I don't think the average person knows that worldwide. I think no matter how many, COVID was horrible, no matter how many people we accept died of COVID, 5 million, 10 million, 15 million across the world, we have to understand that every single year, 1.3 million minimum from our data that we saw recently published, 1.3 million die of AMR every single year globally, 5 million associated with AMR, and it's just getting worse. And to get back to what Dr. Weiss was saying, really the future without any good antibiotics and infections which run rampant means that we can't do any oncology treatment, we can't do major surgery. All the stuff that we take in medicine for granted, we will not be able to do. So I don't think that the world has been sensitized enough, and I think it starts with that, because after that, then there will be innovation and investment in diagnostics, in vaccines, in therapeutics. There will be investment in connectivity and artificial intelligence and everything that goes with it, and point-of-care testing for home. Took 10 years to get an HIV test at home. Hopefully it won't take that long to get home testing for other infectious diseases. But I think it starts with the acceptance that this is a dire situation and getting worse.
Moi, j'ai l'impression que c'est pas un problème dont on parle assez. On en parle, mais je pense pas que autant les gouvernements que les organismes scientifiques le mettent assez en lumière. Alors, j'espère que la journée d'aujourd'hui va nous avoir permis de le mettre un petit peu en lumière et qu'il va y avoir des initiatives un peu plus porteuses et un petit peu plus partenariales, parce que je pense que tout le monde a sa responsabilité. Ça commence par la population. La population doit savoir que ça existe et je pense que tout le monde peut partir de là. Donc, merci beaucoup à vous trois pour vos interventions. C'est très apprécié. Bravo. Merci.
Merci.